you need CRRT or SLED for hemodynamically unstable patient, period. The other thing that we should know is that for patients who have TBI, intermittent hemodialysis is a contraindication. I mean, ICPs clearly go up. There's an osmotic shift that occurs that is so rapid that you end up with flooding your brain, and that can kill the patient. And TBI is a relative contraindication to intermittent therapy. For those patients, you should do CRRT.
Welcome to Critical Care Time, the podcast for everyone who takes care of the critically ill. I'm your co-host, Dr. Cyrus Askin, here with the venerable Dr. Nick Mark, my podcasting better half. Nick, how are you on this fine day?
I'm doing well. I'm going to have to look up the definition of venerable, though. Great to be here, as always. Life's good. It's even better when we get to talk about cool topics in critical care like we're getting to do today. What is on the agenda for this fine day?
Yes, very good. So today, it is another cool topic, a very cool topic. So I'll say that we have the distinct pleasure of having with us today Dr. Kevin Chung, who's a retired United States Army colonel, who is both a practicing medical intensivist, and he is the chief medical officer of our season 1 sponsor, C-Star Medical. So very excited to have him, and hopefully for our listeners, they're excited as well. He's going to serve as our tour guide, really, for the next hour or so as we explore the world of CRRT, which is, for the uninitiated, continuous renal replacement therapy. And the reason why we're really excited to have Kevin on is that he is very, very intimately familiar with this modality, and he's going to approach it from the perspective of a medical intensivist. For you guys that follow along with the show, we touched on this briefly with our colleagues in nephrology, one of whom is actually a nephrology critical care fellow. But today we've got a bona fide medical intensivist extraordinaire with us. Without further ado, let me go ahead and introduce my friend and mentor, Dr. Kevin Chung. Hello, Kevin. Thanks for joining us today.
Thanks, Cyrus and Nick, for that kind introduction and the invitation to be here. Glad to be here.
Before we get into the fun stuff, talking about CRRT, can you tell us your superhero origin story, Kevin? Specifically, what got you interested in AKI and renal replacement therapy?
Yeah, thanks, Nick. So after my fellowship, I was assigned to the Army Burn Center in San Antonio. I did my fellowship at Walter Reed, where I had the pleasure of rotating through several hospitals in the region. And a few of the hospitals basically had intensivists who ran their own CRRT program and basically prescribed CRRT. And so I was able to get a few prescriptions under my belt and get credentialed. And so when I showed up to the Burn Center in San Antonio, that was in 2005. That was around the time that we were starting to receive a large number of casualties from Iraq and Afghanistan. These are young service members, 19 to 25, 30, as old as 40. But it's when I got there, I quickly realized in burn patients, obviously I had taken care of AKI patients and had that experience, but boy, AKI in the burn patient is quite a different story. Just augmented or magnified in terms of degree of illness, the metabolic disturbances, and so on and so forth. And the prevalence of AKI is pretty high, upwards of 70%, depending on the staging criteria. And among those who go on renal replacement therapy, mortality can approach 100% if you don't do anything else or use a different technique or whatever. And so that got me interested, obviously being at the bedside, taking care of these patients, not having any other options. At the time that I showed up for the first 6 months, we did not have CRRT capability. We only had the ability to do intermittent hemodialysis. And imagine that being your only tool in a patient who's anuric, metabolically disturbed, pH is 6.9, K's going up, and anuric, 10 liters up, and the only modality you have available at your disposal is intermittent. And so that wasn't sufficient. Tried to get nephrology on board and help us create a CRT program, but that didn't work out. We had our differences. This is 2005 when a lot of people thought in the community that there was really no difference. That has changed. But regardless, we started our own program. And over time, we were able to treat a number of patients, and that really got me into the field of renal replacement therapy, really by accident. I have to tell you, given the fact that I didn't have any formal training, I was able to learn as much as I could. Really looked upon mentors from outside of my own hospital and other places, those folks that had trained me, nephrology intensivists, etc. And we were able to stand up the program in 6 months and start treating patients, and then started collecting data. And so that's how I got started.
Amazing. So basically born of necessity.
Yeah,
It's really
right.
interesting too. I mean, I think it's really interesting how you have kind of empowered intensivists to be the ones initiating and managing CRRT themselves. Cyrus, you're a beneficiary of that, right? You got trained in that program.
Indeed. Yep.
Um, I think that's a really interesting model. It kind of reminds me, I was thinking about this today. Like, it would be kind of like if I intubated somebody, but then I had to call somebody else to manage the ventilator. Like, I put in this line, can you hook them up to a machine? There's a certain logic to that. How does that change the dynamic of like having an intensivist run CRRT program? Like, what is the interface with nephrology when you do it like that?
Right. Yeah. Thanks for that question. I mean, I probably should start by saying that as an intensivist, if you do a lot of critical care, I think the main philosophy of an intensivist is being able to manage organ failure, regardless of the organ. I know there's some, origins, and historically, most intensivists in the United States were of the pulmonary variety, and hence the focus on mechanical ventilation and that organ. However, as a medical intensivist, I'm a multi-organ failure doc, at least philosophically. And so, to me, renal replacement therapy is analogous to managing the ventilator. And so, as an intensivist, you have to be as skilled or knowledgeable in renal replacement therapy and everything that goes along with it as you are managing the ventilator. And so, really, as I started the program and started, teaching residents and fellows of all varieties, mostly surgical fellows, but also medical fellows, it was really the focal point of, my teaching and just sort of what I was passing on. You have to be skilled at managing the CRT machine, because so many things are impacted by renal replacement therapy. By the way, I should also include that during the pandemic, the KDIGO group, the Kidney Diseases Initiative, changed the terminology to CKRT, so continuous kidney replacement therapy, KRT or CKRT. And so you'll see most papers nowadays are referring to CRT as CKRT in the literature. But for the purposes of this discussion, we'll just stick with CRT for the sake of simplicity.
Man, I'm
Uh,
I'm sure glad they made that change. It sounds like, yeah, definitely was necessary.
Yeah, I posted something on Twitter about it, and I got a flood of interaction about it, and people that were for and against. But anyway, just to go back to your question, Nick, regarding the dynamic. I mean, as you know, in this country, I've practiced in a variety of different settings, to include the burn center where we started the CRT program. I initiated and continued and managed the CRT machine, and so on and so forth. But I've also practiced and currently practice in an ICU where the nephrologists are sort of in charge of initiation and management. And so, really, there are a couple of different models, three different models that exist in the United States. Some units have completely taken over CRT, and they decide when the patient goes on. They prescribe the dose and modality. They decide when the patient comes off, and then they only consult nephrology when a transition is made to intermittent hemodialysis. There's sort of a hybrid model which existed at Brooke Army Medical Center, where this is how we designed it. When we started our program, my relationship with the nephrologist at that time was not very good, admittedly. However, over time, people like Jay Bucci came in, Ian Stewart came in, who were just fantastic nephrologists who just had an open mind. They knew that times were changing. There was literature from around the world that suggested that this is something that intensivists should be able to manage. And so together, along with nephrology, we set up the program outside the burn unit, it in the MICU and the SICU, ACRT program that was sort of a joint program. And so it was understood at that time that we would train all intensivists who had an interest in renal replacement therapy. And depending on who had the credentials and who was on, nephrology would be involved. But depending on who was on, that the person who was most comfortable would make the decision to initiate the modality, and then nephrology would be consulted. Sometimes not, but most often consulted to assist. And it was sort of a co-management that occurred. I think that is the ideal model because you need the best of both worlds to be able to optimally care for the patient. And then the last model is where nephrology is consulted and they decide. And that's where a lot of potential conflict may occur because there are differences in the approach to the critically ill patient. And, frankly, we read different literature, believe it or not. I mean, how many times do you actually go into CJSON and read CJSON articles? Only when you do a search do you do that, but you don't have a subscription for it. And I guarantee, nephrologists are not reading critical care medicine or the Blue Journal. And so I think, because of that, there sometimes could be some conflict, but hopefully the focus is on the patient. And we have enough literature now to suggest that CRT does have a major role in the care of the critically ill, especially those that are metabolically deranged. And we're getting closer and closer to the practice model of those of our international colleagues. As you know, in many international ICUs, either anesthesiologists or other types of intensivists, medical intensivists, pulmonologists, they run CRT in the ICU. Nowadays, my most favorite type of person, specialist, is a nephrology intensivist. No offense to pulmonary intensivists, but nephrology intensivists, I'm sort of envious of them because that's what I want to be. I'm a wannabe nephrology intensivist with no formal training, and so that is the perfect model and perfect individual. I think the best ICU, and we had this for a time and probably still do, where you have a nephrology intensivist, anesthesia intensivist, ER intensivist, pulmonary intensivist, all working together to take care of the patient. I think that's when you deliver the best care.
Yeah, it's one of the great things about critical care is there are people from so many different backgrounds, and it's great to cross pollinate.
Oh,
People who
yeah.
have different background, focus on different things, good at different things. I've
Yeah.
never heard the
Absolutely.
phrase autodidact nephrologist before, but I think you should coin that.
Yeah. Or alternatively, I mean, Kevin, I think there are probably at least a handful of fellowships that would be more than happy to welcome you with open arms as a PGY, whatever, 2025 or wherever you'd be at. And I also do want to, again, echo the fact that I have skin in this game. I was a beneficiary of that program. I, have that credential as well. I love the modality. I do find that, as intensivists who are at the bedside, more than consultants, generally speaking, I think we really do have our finger, literally and figuratively, on the pulse of the patient in a way that uniquely suits us to make some of those decisions. And I totally agree with you that, in my experience, having the ability to liaise with nephrology to make some of the decisions in regards to management of CRRT is very, very powerful. And I wholeheartedly believe that that results in the best sort of the best care for the patient. So I am glad that I was able to reap the benefits. I hope that that becomes more common in the United States. I know we're seeing it more. I hope that continues
Yeah.
to grow.
Right.
With that being said, I think we've introduced Dr. Chung, we've introduced Kevin, and the topic, and I think we can probably get into the weeds a little bit and really get to the heart of AKI initially, and then move on to renal replacement therapy. So obviously, acute renal failure or acute kidney injury, which depending on the literature that you read, those are actually different different definitions. And here I'll sort of plug a resource that I really like and that I would, we don't plug a lot, I guess, on this show. Maybe we should plug more. I don't know. But the continuous renal replacement therapy out of the Pittsburgh Critical Care series. It was published in 2016 by Belmo et al. I'm going through it again right now, and it is just a phenomenal resource, super well written, very digestible. So for anyone who is writing prescriptions or CRRT adjacent, I would highly recommend it. And for those of you that aren't watching, Dr. Chung and Dr. Mark are nodding, so I think that they're probably in agreement there. Would highly recommend this resource. And it's from the introductory chapters of that resource that they cite that 30 to 60%, if not more, of the patients in an ICU, the critically ill patients in an ICU, suffer from acute kidney injury. And they sort of will talk about acute kidney injury as being one disease process, whereas acute renal failure would be acute kidney injury that also manifests with electrolyte derangements or other sort of like sequelae of secondary organ dysfunction. Anyway, whatever sort of lexicon you use, the reality is that kidney disease, acute kidney disease in the ICU is quite prevalent. As Dr. Chung said, those that are on CRRT tend to be some of the sickest of the sick, and so it's really important for us to get an understanding of what this modality is and how we can use it to best treat our patients. Before we do that, I did want to take a moment and ask you, Kevin, how do you actually approach AKI with or without that CRRT component in the critically ill patient?
Right. So, as you know, there are different staging criteria, and I think that's one of the ways our nephrology colleagues, sort of maintain job security. They keep changing the definition, but maybe it's just refinement of the definition. But we started out with sort of a consensus sort of staging criteria called the rifle criteria, which separated AKI into risk, injury, and failure, and then loss and end stage. At that time, that was really welcome, and that's when about the time that I started my practice in the burn center, and so um, I'm really tied to these staging criteria that then evolved to the Aiken criteria, and then the KDIGO criteria, the kidney diseases improving global outcomes consensus statement in 2012. It's 2024, so I got notice that they're convening an update for the AKI guidelines, and so we should be seeing that very soon. But as
So
of right now,
new criteria coming up soon.
Yes.
I bet KDIGO 2 or something like that.
Or
But
perhaps we could bring it full circle and go with the shotgun criteria.
right. Yeah, each time we've refined the criteria for acute kidney injury, and it used to be a 50% decrease in GFR or 0.5 increase over 7 days. That got more refined into that basically categorized you as a rifle risk, AKI-R. Then the Aiken's staging criteria came along, introducing or incorporating some observational studies that demonstrated that creatinine increases of zero point 0.3 from baseline was associated with increased mortality. And so that got incorporated into the Aiken criteria, but over a 48-hour period. So basically, an increase of zero point 0.3 in a 48-hour period of your serum creatinine results in AKI stage 1. There's also a urine output criteria where you must have oliguria for a certain period of time, 6 hours for stage 1, 12 hours for stage 2, 24 hours for stage 3, and then anuria, oligoanuria for 12 hours makes you stage 3. And then the KDIGO criteria came along. They didn't change it that much in terms of the duration, but then included a GFR component, so a GFR drop of a certain percentage over 7 days. I use that very rarely, only in I think in studies that stage the patients and correlate diagnoses with outcomes that they do that. And so for me, using the serum creatinine and urine output criteria to, in my mind, process as I'm evaluating a patient the severity of illness. There's clearly a stepwise increase in mortality when you go from no AKI to stage 1 to stage 2 to stage 3. And I should also include that if you're on any form of renal replacement therapy, regardless of what stage you were on upon initiation, you're automatically stage 3. Um, and so I use those criteria. However, you know that serum creatinine is not the best marker for AKI. You have other reasons for serum creatinine to be elevated, and so it's something that has plagued the field. There have been some biomarkers that have been looked at. I don't know if you're familiar with NephroCheck.
We use that in
Um,
my ICU on every post-op patient. Yeah, it's
Hi,
fantastic.
yeah. That's fantastic. So NephroCheck is a combination of basically tissue inhibitor, metalloproteinase two, TIMP2, and then IGF binding protein, insulin growth factor binding protein 7. So two biomarkers that have been shown to be superior to all the other urinary biomarkers, and it's FDA approved. The Sapphire study over a decade ago sort of brought it to the market. I'm glad to hear that a unit is utilizing that test. In other units, uptake has been slow. There's also NGAL that you may be familiar with. There's a pediatric approval that was, basically a pediatric version that was approved recently, but in adults, as of today, I don't believe there is an approved version of NGAL. So right now, we're limited to NephroCheck as the only biomarker that can complement and detect AKI early. Some other sort of ways that you can detect AKI early for me is looking at drug levels. If in burn patients, everybody's on antibiotics all the time, and we're always checking vanc levels. And so, if that vanc level troughs is starting to creep up, you notice, and you're like, I wonder what's going on there. And so it's something that could be a marker of, early marker of AKI that you should be paying attention to. And so, I think, what we're talking about here is ischemic ATN, most likely mixed in with some drug nephrotoxicity and less commonly toxins such as myoglobinuria from rhabdo and other etiologies. But in general, it's probably there are many different reasons for patients to get AKI or develop AKI, but most likely it's due to decreased end organ perfusion, and we're trained to trying to optimize oxygen delivery and improving and maintaining organ perfusion for all organs. And paying attention to the kidney is smart because that's one of the first organs that goes down. So,
So I'm going to go a little bit off our plan here and ask a question.
sure.
You listed a bunch of causes that can contribute to or cause AKI. One thing I didn't hear you say was contrast.
Yeah, yeah, it's highly that's something that I've learned over my Twitter feed, that contrast-induced nephropathy is something it doesn't exist. I think it's important for us to be careful not to introduce any potential new insults. And so, in patients who have established AKI, I am still careful not to introduce them to that potential insult.
And I think that's
But
consistent with the literature too. I mean, that's
it
what that I've
is.
come
It is.
across. So
Yeah, and also there's there are different types of contrast that's available that has varying degrees of impact in terms of inducing contrast-induced nephropathy. I used to have an entire talk on contrast-induced nephropathy and mucomis and all that stuff, but then I started encountering all these studies that demonstrated mucomis just artificially lowers serum creatinine, and really, contrast-induced nephropathy is not a thing. And I'm starting to become sort of be led into in terms of philosophy in that direction.
I
yeah.
really appreciate the subtlety of your answer there. That because I mean I think people sometimes over broaden that to say
Yeah,
that like for an ED patient presenting with hypoxia, even if their creatinine is elevated, getting the scan to rule in or rule out PE is almost certainly the right move, right? The contrast is not the issue. The life or death diagnosis is the issue. That's not to
right.
say that like the enormous contrast load of shooting somebody's coronaries and left heart, right heart, doing all this other stuff in the cath lab is not is harm free.
Yeah,
And so there's kind of a dose makes the poison element to contrast as well. That like,
agreed.
For a life or death scan is one thing. For like a huge diagnostic thing, that's a little different.
Yeah, I don't disregard it, completely, and I'm still careful, as I was trained. But I am paying attention to the chatter and the new literature that suggests it's not as bad as we think it is.
Yeah,
Right.
and
We were sort of brought up to fear it, and it turns out it's kind of like, when you're a
Yeah,
kid, you think that quicksand is going to be this big problem when you're an adult, and it turns out quicksand is not really a big issue.
Yeah, and we for those of you that follow the show, you might remember in episode 5 where we did our first installment of Zorses and Hebras, we talked about contrast-induced nephropathy, and sort of how in the vast majority of cases, if the study needs to be done, you kind of just do the study. I think that's what most people would agree on. It does require a little bit of discretion, I suppose, on the part of the intensivist if this person is either at risk or recovering from an AKI. No one wants to be the no one wants to bring that death knell onto a patient if they can avoid it. But I think that's a very Kevin, I think that's a very reasonable approach. And one other thing as you were kind of discussing your approach to AKI that I was reminded of is, we talk about drug levels rising in patients as perhaps a harbinger of what's to come. Taking a step back just critical care in general, one thing that I learned early on my training is um, watching, not related to kidney disease, but also in a similar concept is like if you start to see a patient's insulin needs increasing,
right.
that's one of those things where like you may not actually see the blood sugar because it's being covered by insulin. You may not be catching it
Yeah,
acutely, but that's, at least in my experience, can be indicative of badness around the corner too.
right.
So both things that we should be looking for, and obviously on critical care time, we want to help foster the best habits in our budding intensivists or actively practicing intensivists. So
Yeah.
there you go.
Pattern
Um,
recognition. Yeah, definitely.
Nick, did you have something you wanted to
I was
contribute?
just saying,
Sorry.
so I think that's a great overview of what AKI is, how to recognize it based on the sort of evolving criteria, and a good overview of the sort of like approach and philosophy of it. Since we're going to talk about CRRT, we might as well start there. So now, let's say that we have a patient with AKI stage you choose. How do you approach them at this point? When do you think about a diuretic challenge? When do you go straight to CRRT? How do you make those kind of decisions?
Right. And so, most often in our practice, when somebody is developing AKI, it's in the setting of some kind of global insult, and the host response is completely out of whack, and you're dealing with somebody who over time starts becoming oliguric, and now because of their relative oliguria they're becoming fluid overloaded, and so in those patients, as they approach a positive fluid balance, in general I'm pretty liberal, as many are, with Lasix administration, just to maintain an even or negative fluid balance over time. I think the literature is pretty clear on that way of managing these patients. But when you start falling behind, that's when you may be headed towards AKI and needing renal replacement therapy. Um, I'll try my best to try to avoid CKRT, insulin or Bumax drip. Dare I say albumin along with that in the right individuals. Yes, it works. I've seen it work over and over again in ARDS who are hyperproteinemic, and there's literature that makes that exception in those patients
In order
using.
to be transported to the kidney, it has to bind to albumin. So it stands to reason that if you don't have any albumin, you're not going to deliver much Lasix to the kidneys.
Yeah. The limited literature that's available in critically ill patients
R-
suggests that it's helpful in patients who have low
Last
protein.
time I looked, I think there was as much literature in guinea pigs as there was in humans. But yeah,
Yeah.
so it goes.
So anyway, so you try your best. I even throw in diureral, and most often, by the time I'm thinking of diureral, they're already diuretic resistant, and so And that's when you start thinking about, okay, maybe I should be thinking about initiation of renal replacement therapy, and depending on what ICU I'm in, I'll contact a nephrologist, or I'll just talk to the ICU nurse and get the machine set up.
That's a really great point, Dr. Chung. That sort of diaryl or chlorothiazide, for those that haven't used it before, does provide an additional element of diuresis by way of blocking the sodium chloride transporters that are located in the distal convoluted tubule of the nephron. So it kind of allows you, in the setting of loop resistance, to prevent water reuptake within the nephron, and it can augment your diuresis. When it works, it's great. Unfortunately, it doesn't work all the time.
And I think it's probably worth emphasizing too that a Lasix challenge isn't 40 milligrams of Lasix once.
Yes, yes.
That
At,
like
at a minimum 80, if not 160.
exactly, the joke from House of God, or not the joke, the rule at the beginning of House of God is it's BUN plus your age, and sometimes that's actually about right, that like it really is a big dose. I think people often have this somewhat irrational fear that like they're going to cause harm to the kidney by giving too much diuretic, but of course the way that diuretics can harm the kidney is by causing you to be pre-renal. You lose too much volume, and so
Right.
if they don't work, they can't hurt.
Yeah, yeah, and really, it could be diagnostic, right? So you give a squirt of Lasix, and it opens up the floodgates. Hey, you're good to go. They had it to give, and the renal function is okay.
Right.
If they didn't,
Often these people are profoundly volume overloaded with a high venous pressure. You diurese
right,
them, and their creatinine comes down the more you diurese
right,
them.
exactly,
Really
and
quick. Oh,
yeah,
go ahead. Sorry.
oftentimes, just real quick, oftentimes you think, oh, I'm giving Lasix, I'm going to try to reverse renal fit. No, you're not reversing anything. You're just trying to make fluid management easier. And so it's all about fluid management, really, as the goal of therapy.
Just, I think that like one important thing in physiology, whether you're talking about the brain or the kidneys or pretty much any organ, is to think about perfusion pressure. And
Right.
in the case of the kidneys, the perfusion pressure is your MAP minus your CVP. So often
Hmm.
in these profoundly volume overloaded patients, their CVP is high and their MAP is low, so their kidney is hypoperfused. Giving diuretic lowers the CVP and then improves renal perfusion. And I think that's a core concept for people to sort of grok in trying to understand why diuretics can help the kidney.
Yeah. Excellent point.
So with that, I think we've done a nice job of introducing the concept of acute kidney injury, how we kind of approach it. I think we're sort of all on the same page there. I want to turn our attention now to really focus on CRRT, or CKRT, as it were. So really, for the uninitiated, CRRT is continuous renal replacement therapy, or CKRT, continuous kidney replacement therapy, and it is a mechanism by which we can manage patients with acute renal failure, acute kidney injury. And it also kind of can achieve other goals depending on what it is that you're faced with in the ICU. It should be noted that you really need to have good large bore vascular access to do this. So typically it's a dialysis line or a trialysis line if it's got a little pigtail on it, placed normally in either the IJ or femoral. We kind of usually will avoid subclavian access for those, although sometimes it is what it is, and you'll do that. Other times you might get lucky. A patient might have a tunneled Hickman or something for whatever reason, and you might be able to use that. But point being, you've got to have good access. And then, of course, you need to have a CRRT machine, and those come in different flavors. And probably the most important thing is you need to have the manpower to actually, or woman power, as it were, the person power, to sort of run that. And that's really going to be the all important CRRT nurse, or a CRRT trained nurse, who's usually going to be a ICU nurse that has done the additional training and is comfortable managing both the circuit and the patient. In some cases, they might get lucky and they're just managing the circuit, but generally speaking, they're doing both. And so obviously, this is both resource intensive, and placing that line is not completely devoid of risk. There are, of course, potential hazards of placing a large bore intravenous catheter. Gone are the days of arteriovenous, renal replacement therapy, where we're using arterial pressures to sort of provide the force necessary to dialyze or filter or whatever. So really, it's venous access now. That being said, of course, veins can bleed too, and this is also a costly it's a costly endeavor. So, with all that background, Kevin, can you give us kind of an overview of the tool? Why it's used, who it's used for, and sort of like help me understand why we would reach for such a resource intensive modality versus maybe some alternatives.
Right. So I think the alternative would be intermittent hemodialysis. And for a long period of time, that was the only modality available in many ICUs. But over time, that's changed, and many ICUs have decided to absorb the cost of implementing CRT programs or hybrid programs like SLED programs. And so maybe I should start sort of talking about CRT in general as a concept and sort of try to demystify it for our audience, if I may.
Please.
So, I've done this many times in the past. Usually I use a whiteboard, but maybe we'll share a little diagram. But so imagine garden hose, blood going through a garden hose where basically it's porous and stuff like exudate can leak through the side of the hose. And so it's a hollow, tube that blood is flowing through. Now imagine thousands and thousands of these hollow fibers that are packed in parallel in a plastic casing, cylindrical casing. Blood goes in through one end and out the other, from the patient through a pump back to the patient. I used to quiz the residents. So if you're doing that and just that, what are you doing? And I would give them a choice, multiple choice, scuff, CVVH, CVVHD. And invariably, everybody would pick one of those options. But it was a trick question. It was none of those. It's basically, if you're just doing that, you're doing extracorporeal blood circulation because you're doing nothing to the blood. And so let's say blood is going through that hemofilter, consisting of those very, very fine hollow fibers. And in between those fibers, you exert a negative pressure or, basically hydrostatic pressure alone. Just dropping the filter can do the same thing. But you induce a negative pressure such that you're removing 100 cc's an hour. You're controlling what's removed. So as blood is flowing through that tube, the hemofilter, through the side ports, that negative pressure is induced, and let's say 100 to 500 cc's an hour is removed over time, 24/7. That's scuff, slow continuous ultrafiltration. So that stuff that's coming out is ultrafiltrate. You're removing fluid every hour. You're negative 500 cc's, let's say. All right. So let's say you're doing the same thing. So take it to the next step. And now instead of just having blood go through and having a negative pressure, you don't have any negative pressure. You're now running a fluid counter current to the blood. And basically, we'll call it dialysate, but it's a perfectly electrolyte balanced solution, and you're basically running that fluid in the extracapillary space, so in between those fibers. It's a semi-permeable membrane. Blood is going through the hollow fibers, and naturally a concentration gradient exists. And so the dialysate flow maintains the concentration gradient. So let's say the dialysate has a potassium of 2 and the patient has a potassium of 8. Naturally, through that semi-permeable membrane, as blood is passing through that hemodialysis filter, it's going to dump into, via the concentration gradient, into that interstitial space and then get removed, and it goes outside the filter, either goes to a bag or the sink. That's called effluent. Okay. So let's say you add a negative pressure on top of the dialysate that's flowing through, and now you want to remove a little extra fluid. So you're dialing in more ultrafiltrate on top of the effluent, but what's coming out in total is the effluent, if you know what I mean. And so that's dialysis. And if you're doing that 24/7, that's CRT or CVVHD. If you're doing that for a very brief period of time with high blood flows and high dialysate flows, you're doing intermittent hemodialysis. If you're doing that over 8 to 12 hours, it's SLED. Now, what's very interesting is that, let's say the Fresenius is a hemodialysis machine that gets wheeled into the ICU to deliver intermittent hemodialysis. Well, you may notice that for the Fresenius machine, you're using tap water, running it into the machine through a reverse osmosis system that's present there. You're purifying the water. It's not sterile, it's pure. Okay. You're adding a bunch of electrolytes, you're dialing in exactly what you want, and then you're using that as dialysate. Dialysate does not have to be sterile. It's not introduced into the bloodstream. It's just using that fluid for the purpose of maintaining that concentration gradient.
Just
So
just
if
just
you're
to just to add a detail here, I'd always wondered this too. It's like there's the dialysis machine, and then there's that other cart with those like
yeah,
things that look like tanks on it.
yeah,
Like
yeah,
oxygen tanks, but
yeah,
they're different color. That's
yeah.
this. That's the reverse
That's
osmosis
reverse
machine.
osmosis. Yeah, that's a reverse osmosis. Not very different than the reverse osmosis system you may have at home to purify your water. And so, by definition, pure is like, one colony forming unit, 1 degree greater in terms of bacteria than sterile. So there are different definitions. And so you cannot infuse into the vein a pure solution. It's not sterile, So anyway, so that's with the Fresenius machine. When you're doing that, you're doing hemodialysis. Well, what's interesting is that that machine has a CRT chip so a CRT function, and you can run that machine for 24 hours, right? So by definition, if you're doing hemodialysis for 24 hours, even if you're using the Fresenius, you're doing CRT, right? If you're doing it for 12 hours, you're doing SLED. Okay, so most often that machine is used to perform in the ICU a hybrid modality, which is SLED, oftentimes.
And that's
Uh,
slow, low efficiency dialysis.
right, slow, low efficiency dialysis. On the flip side, if you are doing CVVHD using either the Next Stage or Prismaflex or now Prismax, which is another new machine that has come online, you're basically using a machine that's designed for continuous renal replacement therapy, right? And so they have all the nice pumps, they have premixed solutions. By the way, those premixed solutions are sterile. I'll explain why that's important in a second. Okay, so you're using that same fluid, and it says replacement fluid on it if you read the bag, but you're using it as dialysate,
Right.
right?
Right.
And so let's say you do that 24/7, that's CVVHD. However, there are programs where they're trying to, be mindful of cost and workload, and they do that intermittently just at night. This is intermittent renal replacement therapy.
Right. Right.
So the barrier is less about the machine used and more about
yeah,
how the machine is used.
right. How the machine is used and what you're doing. So dialysis, that you leveraging the concentration gradient, is diffusive clearance. Okay. Not to be confused with convective clearance. It's like trying to explain pressure control versus volume control, right? So diffusive clearance is a passive way of utilizing the concentration gradients to remove solutes that are important. And usually that's effective at clearing solutes like smaller solutes, electrolytes, and so on and so forth, BUN, electrolytes like potassium. So what is convective clearance? And so think about this. So you have the same blood path, right? So your blood is going through the hemofilter. And that's going at a certain blood flow, 200, 300 cc's per minute, and then in that extra, capillary space, right, interstitial space, you exert a negative pressure that's so abundant that you're removing like a liter or 2 liters, right? If you did that and only that, the patient would be negative 2 liters an hour, right? Instead, what you're doing is you're introducing replacement solution. This is why you call it replacement solution, because back in the day when you were doing CAVH, you use hydrostatic pressure to basically induce more output from that filter through that process, with convective clearance being the major driver of fluid coming out of that filter. And then you would replace the patient so that they would be even, right? And so that's why it's called replacement fluid. And so that when you're doing that, you're basically dragging solutes across the membrane as blood is going through the filter, through those hollow fibers, and in that interstitial space, electrolytes, middle molecules, phos, drugs are being dumped into that interstitial space. And so a lot of times the way we prescribe, and that's basically hemofiltration. If you do that 24/7, you're doing CVVH, okay? CVVH only. And so the reason I mentioned that the replacement solution being sterile is that for those CRT machines, those fluids, they're designed to do CVVH, right? And so that replacement fluid doesn't go in that extra capillary space. It goes into the patient. Basically the extracorporeal circuit, you can either introduce that fluid pre-filter, and the advantage here is you're mixing with the blood, so you're diluting the blood, or post-filter. The advantage there is you're optimizing clearance because the blood, as it passes through the filter, you're basically increasing the efficiency of solute removal, right? And so the PrismaFlex, you can do 50-50. So 50 pre, 50 post.
And in that
So
case, I guess my understanding is the pre-filter substitution or replacement fluid is nice because it can increase the longevity of your filter. But the problem is you're essentially dialyzing or filtering blood that has an additive, so you're not like your efficiency
the
is
efficiency
reduced.
is
In
impacted. Yeah.
theory, unless you're dealing with a situation where your filters are constantly being replaced because the blood is gumming them up. And so I think that can sometimes be a moot point, but certainly my understanding is with the post substitution fluid or replacement fluid, that fluid is directly changing the electrolyte concentration and the serum bicarbonate in that patient with
Right.
downstream after the filter has already been utilized.
Right. Right. So that has its own set of like tricks of the trade. If you have filters that go down quickly, you do more pre-filter or 100% pre-filter, so on and so forth. So that's CVVH. Now, can you do that intermittently? Sure, if you want to. I mean, you can do intermittent using the PrismaFlex or the Prismax, but nobody really does that. Maybe if you're doing it at night only, doing that intermittent renal replacement therapy, maybe. But if you're using the Fresenius, remember I told you the fluid that you're generating is pure. You cannot use that fluid, that dialysate, as replacement solution. Okay. And so you can't do just CVVH on the Fresenius. That is the limitation. You can do some hemofiltration, so CVVH-DF, and I'll explain how you do that in a second. So go back to the next stage or the PrismaFlex. Both have its advantages, and that's a whole nother talk. But let's say you're doing the blood, right? You have replacement fluid going at 2 liters an hour, and that's what's coming out also into the sink, you know. Um, and at the same time, you introduce dialysate as a countercurrent, right? And so now 24/7, you're doing both hemodialysis and hemofiltration. So CVVH-DF. Okay. And so you set the dose, you set the blood flow, usually 100 to 400 cc's per minute. You set the replacement fluid rate at like 1 to 2 liters an hour, the dialysate rate, 1 to 2 liters an hour. And then you're doing CVVH-DF. And then you can dial independently the ultrafiltrate, okay, how much you want to remove every hour. And so that negative pressure goes up by 100 or 200 extra, so that you're removing extra fluid every hour, and all of that is effluent because you now have dialysate that's in there, and then all the convective clearance that solutes that have been pushed through that semi-permeable membrane, and then the extra solution or the fluid that you're driving across the membrane to remove. So that's how you get a negative fluid balance. Now, going back to the Fresenius machine, let's say you're doing, and this is why this is so important for intensivists to know this, because you need to know what modality of renal replacement therapy your patient is on, because it affects drug levels. Okay. For example, vancomycin is removed very efficiently with hemofiltration, convective clearance. Not so efficiently with diffusion or dialysis. And so if you're doing strict dialysis, your drug levels may vary. You may have to redose, based on your dosing interval, less frequently. But if you're doing hemofiltration or CVVH strict CVVH, a lot of times they're getting dosed like they have normal renal function because you're removing it, right? Say you have somebody on a Fresenius and they're doing CVVH, or no, I mean intermittent hemodialysis. Guess what? The nephrologist may prescribe a little hemofiltration on top of the dialysis. How do they do that? They turn up the ultrafiltrate rate to a liter, and then they give a liter of normal saline at a liter an hour. So that's how they add an F to the HDF.
I think that's a fantastic walkthrough of all the letters and what they mean. And I think that's a really key point about the difference between diffusive and convective clearance, and
Yeah.
why, even if you're not the one writing the prescription, you need to know what the prescription is, because it's going to have profound implications both for fluid balance, but also for all your drug levels and everything else. And,
Yeah.
just a plug for why having clinical pharmacists in the ICU is so important when people are
Absolutely.
transitioning
Yeah.
from
Yeah.
not on renal replacement to one modality to a different modality.
Yeah. You have no, if you have a patient on a drug that's you're not measuring, um, you really, really need to know exactly what mode and dose of therapy you're delivering, because based on that, there are recommendations that are scattered in the literature that your PharmD can help dig through to give you an optimal dose.
And even if you are checking levels, that's good. But I mean,
Yeah,
implicitly in checking levels, you're seeing, what the drug levels were. You're kind of like driving,
yeah,
looking out the rear view mirror, right? Like there should be some level of anticipation too. Like we're going on to this modality, we should increase preemptively, kind of thinking.
yeah. That whole Venk example is on the boards almost every year. By the way, critical
Yeah.
care boards.
Yep, that's right.
So I want to take a moment to just summarize some of what we talked about, because I know there's more we want to get to. I know we want to talk about some of the specific indications and utilizations, and a few other definitions. But just kind of for our listeners, and please, Kevin, correct me if I'm wrong. We've talked about ultrafiltrate, which is essentially the volume per unit time that you're removing from the patient, and
Hmm.
effluent, which in the setting of scuff, of slow continuous ultrafiltrate, is essentially the same thing, although we don't use that term. We don't really talk about it as effluent.
No.
We really use the term effluent when there is replacement fluid or substitution fluid being added to the
Hmm.
patient, kind of as it's entering the filter. And then what is coming out into the bag, so to speak, is a combination of your ultrafiltrate and what you've added to the patient's blood, i.e., effluent.
Yeah, that
Um,
is driven across the membrane into
exactly.
the extracapillary space into the bag. Yeah,
And that really gets at this concept of a convective force, a
yeah,
difference in pressure gradient, or a difference in pressures, i.e., a pressure gradient that causes that fluid to exit the filter itself. Uh,
yeah.
in comparison to a dialysate, which is, as you said, it's generally the exact same bag of fluid. It's just the
Yeah.
way it's being utilized. So you're kind of running it in a current countercurrent model. It's flowing typically, in most cases, in the opposite direction of your blood flow. It's setting up that concentration gradient where, yes, things are going to move back and forth, but on aggregate per unit time, things are going to move from areas of high concentration to low concentration,
Right.
and that's going to end up sort of what that's going to end up in the bag. That's going to be your effluent. It's going to be a function of that diffusive force. And
Right.
if you combine the powers of a convective force and the powers of a diffusive force, that's when you end up with CVV-HDF, or a
All the
combination
letters.
of, yep, all the
Yeah.
letters. You end up with a
Yeah.
combination of that filtration force through convection, but then you also get the powers of dialysis through the diffusive force that you've set up.
That's correct.
Um,
I've often thought that somebody should write a paper about the analogy to coffee, and like pressure gradient like espresso
Right.
versus more diffusion like French press.
yep,
Because
yep.
I
Right.
think like there's
True.
a world of people in the critical care space who are also coffee fanatics who would eat that up.
Right. Yeah. That's a great analogy.
Yeah. So I think that's so basically, then, to kind of sum things up again, really hammer it home. So we talked about scuff as being, you're just pulling off ultrafiltrate. It's a means to control volume. We talked about CVVH, which is there's no dialysate used in that setting. What you're doing is you're adding substitution fluid, however it is that you choose to do that. And the idea there is that you're taking advantage of that convective force, the pressure
Yeah.
difference. With
Yeah.
CVVHD, you're not adding substitution fluid, but you're adding that countercurrent flow with your dialysate going in the opposite direction. And then finally, as we said, if all the letters are present, you're doing both. You're adding your substitution fluid and you're
Right.
adding your dialysate, and that's how you're kind of attacking the problem from different perspectives.
Right. So, as an intensivist, you need to know what modality the patient is on because it impacts a variety of different things that you're dealing with on a day to day basis. And then also the fluid balance. Obviously, the ultrafiltrate you need to be able to dial up and down. What's really also important to really keep in mind is dose. Dose has gotten a ton of press in the literature over the past 2 decades, and it's something that has really been solidified as conclusive in terms of what's standard of care. Um, Prior to the ATN trial and the renal trial, both New England Journal papers back in the 2000s, 2009, or something like that, we did not have a standardized way of delivering dose. So somebody, let's say you're talking to nephrology and you're saying, okay, let's put them on CRT. They would humor us and just put them on a puny dose of CVVH or CVVHD and run 1 liter an hour and a tiny blood flow of 50 cc's per minute. Well, now we know what the minimum dose is that is acceptable in the community. It's 20 to 25 cc's per kg per hour delivered. So, how is that measured? That's by looking at the effluent. Regardless of mode, if your effluent is at least 20 to 25 cc's, okay, per kg per hour, you're delivering a sufficient dose. The really crude method of deciding whether or not you have a sufficient dose is a uremic reduction ratio that you track. So basically, if a BUN is one day 100, um, the next day you want that URR, uremic reduction ratio, to be about 60%. That is equivalent to an acceptable dose of hemodialysis with one session. So 60% decrease in your BUN is what you expect. And so nowadays, if you're not delivering 20 to 25 cc's per kg per hour, you're not delivering a sufficient dose of an acceptable dose of CRRT. Um, what's important to realize also is that going higher, okay, to 40 to 45, there's no difference between 20 and 45. We're going to exclude 70 and 80 and 100 just for the sake of for this setting. But between those two doses, going higher doesn't necessarily improve outcomes in two randomized controlled trials. Here's the thing, however. I'm always of the mindset of individualizing the dose of therapy to what you're seeing in front of you. And so if you have a patient who's severely metabolically deranged, um, and potassium's like out of control, you're about to induce an arrhythmia, and the pH is 7, and you have catecholamine resistance, would you start at 20 cc's per kg effluent dose? No, I always start a little higher, and I did this a lot with burns until I got control of the metabolic dysfunction and derangement. And once I achieved electrolyte balance and the pH became more reasonable, something that was compatible with life, I would then go down to 20 cc's per kg per hour. So individualize the dose, especially in the first early stages of therapy. That's not in the literature. That is something you have to negotiate with nephrology. It makes a lot of sense, and more people should do that.
No, Kevin, correct me if I'm dumbing this down a little bit, but I think about dose as the amount of blood that's like purified per time. So when you're
Yeah.
saying 25 mils per kg per hour, you're basically saying like this volume of blood is getting cleaned in that time.
Well, you're measuring effluent, so the combination of either the replacement fluid that gets driven across the membrane or the dialysis fluid that is going through that interstitial space. So, in combination, all of that together on top of the ultrafiltrate, what is being removed is the dose, basically.
Fair point. Okay, yeah, right. So it's not just what's being removed from the patient; it's also what you're putting in that you're taking back is also
Yeah,
counted in that.
exactly. Yeah.
So
Yeah, thanks for clearing that up.
if there is no substitution fluid or replacement fluid, let's say, then the dose would be the blood itself that's getting treated. Is that correct?
No, I mean just ramping up the blood flow, that can increase, sort of some clearance. However, and it could maintain filter life, and so that's a strategy that you can use. But the only accurate way of measuring delivered dose is looking at the effluent rate
Got it. Okay.
per hour.
Got it. Thank you for clarifying that.
Yeah.
Okay, so now that we've discussed at length some of the concepts behind CRRT, we've gone over the definitions, we kind of understand what the letters mean and why it's important. Let's talk about the sort of implicit comparison between continuous versus intermittent therapies. Why do continuous?
Yeah. So if when you look at the literature, in total, and at equivalent doses that are delivered, it's pretty consistent that there's really no mortality benefit when you compare intermittent versus continuous modalities. And then, as an extension, if you could try to compare CVVH versus CVVHD or CVVH only to CVVHDF, sort of variable outcomes, and really no differences in outcomes um, in between those modalities. But back to intermittent versus CRT. Why would you do CRT? Well, it's clear that in patients that are hemodynamically unstable, that the amount of solute clearance that occurs within the context of intermittent hemodialysis, because you're trying to achieve solute clearance in the period of 4 hours that you could spread out over 24 hours. Same thing with volume removal. But it's mostly solute shifts, that's osmotic shifts, that really causes hypotension, we think. And it's clear that when you put somebody who's hemodynamically borderline or unstable on traditional hemodialysis, they need more pressors, and so when the investigators designed the ATN VA ATN trial, where they compared intensive dialysis and renal replacement therapy versus less intensive, they designed the trial such a way that if the patient was hemodynamically stable, they allowed for dialysis, but in the intense group, they did it daily. So basically, a high dose. In the less intense group, they did Monday, Wednesday, Friday in the ICU. Okay. In the same protocol, if they were hemodynamically unstable, they either did SLED, so spread it out over 12 hours, or CRT. So implicit in that is this concept that you shouldn't put hemodynamically unstable patients on intermittent. Okay, and so the KDIGO guidelines, and as an extension internationally, the renal trial, everybody goes on CVVHDF. Okay, so the renal trial compared two doses of CVVHDF, 25 versus 40. Again, no difference in the doses. However, everybody got put on CRT. Um, so in the KDIGO guidelines, they say, they make a statement that, there's really no difference between the modalities and you choose dealer's choice or whatever. However, if the patient's hemodynamically unstable, continuous modes of therapy are preferred. Okay, so that's number one. Number two, there's emerging evidence that suggests, and this is there's a systematic review, actually meta-analysis of and post hoc analysis, I should say, of the renal and ATN trials that suggests that this. And in the ATN trial, what they did was if the patient was in the intense group or the less intense group, if they basically were hemodynamically stable, they would be on intermittent, and then if they became unstable, they got switched to CRT, and then back to intermittent, and then back and forth. So this intermittent versus CRT, and then or CRT got started, and if they became hemodynamically stable, they would get switched to intermittent. So this matching, like mixing of different modalities in the same patient, going back and forth, right?
Mm.
Versus CRT alone, okay, where you do CRT for the duration of from the beginning all the way until they have renal recovery or need to be transitioned. That strategy compared to this mismatch back and forth or intermittent alone. In terms of long-term renal outcomes, the strategy of doing CRT is superior.
Mm.
There's significantly less need for long-term dialysis in that population compared to the American model of going back and forth, back and forth, back and forth.
And is the
And
idea
so,
that the hemodynamic shifts of
yeah,
going on and off are causing injury to the kidney, which leads to permanent renal failure, or what's the thinking there?
physiologically plausible. That
Hmm.
that is the hypothesis. Yes, and so so I think from my perspective, if the patient is hemodynamically, and notwithstanding this whole long-term outcomes thing, I think that needs to be validated in a multi-center trial, head-to-head, intermittent only. Versus, I'll tell you though, if you do a trial like that and you're assigned to the intermittent group and they're hemodynamically unstable, they'll probably put them on CRT. You know what I mean? So it's you need CRT or SLED for hemodynamically unstable patient, period. Okay. Um, the other thing that we should know is that for patients who are like have TBI, intermittent hemodialysis is a contraindication. That, I mean, ICPs clearly go up. There's an osmotic shift that occurs that is so rapid that you end up with flooding your brain and your brain swells more, and that can kill the patient. And so intermittent is TBI is a relative contraindication to intermittent therapy. For those patients, you should do CRT. So for that reason, CRT is preferred in that population. But as far as I'm concerned, if you have a hemodynamically stable patient, taking into consideration potential long-term consequences, it's okay to be all right with just having intermittent hemodialysis. If you take care of a population where a large proportion of your patients are hemodynamically unstable, metabolically deranged, CRT is definitely an option that you need to have in your toolbox, because that's what the KDIGO guidelines has stated and recommend. And so I'm really anxious and looking forward to the update of the KDIGO guidelines, probably to 2025. I'm thinking to make a statement on the modality of choice in the ICU patient. Okay, uh, timing very quickly. When to initiate is a huge controversy, early versus late, and you always get into arguments if you're a nephrology driven, consult model where they decide you have to justify initiation in your patient, and a lot of times they'll be like, no, I mean, you know, uh, they don't meet criteria yet. There have been multiple studies, the AKI, the AKI study, Ideal ICU, Start AKI, and then there was an AKI 2, AKI 2. In general, in summary, earlier initiation of any form of renal replacement therapy versus late, there was no difference. However, uh, in the late group, they met criteria for late hemodialysis or renal replacement therapy if they had organ edema, and depending on the study, diuretic resistance after one dose of Lasix. And how was that defined? Pulmonary edema, evidence of pulmonary edema, and either a PF ratio less than 200 or an FiO2 of 50%. Okay. So when you're
So most
making an
ICU
argument,
patients.
yes, like 90% of your patients who
Right.
are overloaded who stop making urine. It's like so. The other day I had this come up because I was trying to convince a very traditional nephrologist in my community practice that this patient needed to go on CRT, and he was like, "Why? He doesn't meet criteria." I'm like, so I started talking about the AKI study, IDIC. I was like, look, all these patients got rescued when they're they have organ edema. And the patients on 80% FiO2, whited out lungs, tell me, and they're 20 liters positive, tell me they don't meet criteria for rescue, right? So,
Right.
okay, no problem. No argument there. So
And
that is,
conceivably, you start a day sooner. That means that you pull off, 2 liters, that
exactly.
much sooner, which
Yeah,
hopefully means you liberate from the ventilator that much sooner.
exactly. And so what the bottom line is, yes, early versus late across multiple studies hasn't shown benefit, but really late, in my opinion, is still early compared to what we were doing 20 years ago.
Mm.
Right. So think about it. And so like, and the other criteria for rescue was a pH less than 7.2. Okay. And, AKI for 48 to 72 hours. So stage 3. And so any of those criteria is still considered late. And so you can use the data across 4 studies. In fact, AKI, the AKI 2 study suggested that there is a too late. In fact, they did late versus too late, later, and the later population had a worse outcome. And so now we're sort of, as a community, understanding what the right timing is. And in general, it's when a pH is less than 2, when you have organ edema, okay, by whatever definition you utilize, and like you said, most of your patients have organ edema, but when they have AKI, 50% FiO2 or PF ratio less than 200, or they're oliguric for an oligoanuric for 48 to 72 hours. Those variables, you should be able to make the argument to initiate.
So
And that was that was a pH of 7.2. You said
7.2, yes.
Go.
Yes.
So let me ask kind of a logistics question here. So, I work in a part of the country where I work at a big, like, tertiary quaternary hospital, but there's many smaller rural community access hospitals, and
Right.
most of them do not have the capability to do CRRT. In fact, probably almost all of them don't have that capability. So we
Right.
accept a lot of transfers for this.
Right. Right.
It seems like something we should probably be doing more of and earlier as sort of a practice.
Right.
Then,
Right. When they reach the late inclusion criteria for all across 3 multi-center trials. And I bet you KDIGO will comment on this. It was very vague in 2012, but it's clear now when, when you should start. And it's, late, but for us, it's still early.
right? No, I think that's a really important thing to emphasize too for our listeners, which is that if you work at one of those hospitals that does have CRRT, you should
Yeah.
be thinking about, making sure it's not too late for patients who are
Yeah.
coming there for it. And if you work at a
Exactly.
hospital that doesn't have CRRT capability and your
Right.
patient is hemodynamically unstable and maybe can't get IHD, or maybe you don't even have IHD,
Yeah.
you should be thinking earlier about transferring them to a center where they can get that.
pH is 7.2, organ edema, oliguria for more than 3 days.
perfect. Super helpful, Kevin. Now,
Mhm.
there's still some topics that I do want to get to. I know this is going to be a lot of great content for our listeners, and hopefully an episode that people will keep coming back to. That's kind of the goal here on Critical Care Time, is to give people a one-stop shop for some of these really important concepts in critical care. So I don't think we could talk about CRRT without discussing anticoagulation a little bit, because that's always a concern. That's an issue that comes up. Earlier in the discussion, we did talk about how substitution fluid or replacement fluid can be used to help sort of, quote unquote, thin out the blood a bit as it's moving through the
Right.
filter. It can help reduce the clogging that occurs within the filter, and potentially help with efficiency in that regard. Be very clear can help with efficiency in regards to the number of filter changes. But the
Right.
other real big concept here is actual anticoagulation with things like heparin or perhaps citrate. So
Right.
can you walk us through how you approach that question of, do you anticoagulate? How do you anticoagulate? And really, what are the options that are out there for our listeners who might be using this modality?
Right. So I did a prospective observational study a little while back, and we looked at practices across multiple burn centers, and it really aligned with the rest of the country in terms of ICUs. But about a third, so citrate versus heparin. There are a few that do direct thrombin inhibitors, but we won't talk about that for the sake of time. But in terms of head-to-head citrate versus heparin, there's a clear advantage that's been demonstrated over and over again. In fact, in 2012, KDIGO recommended citrate as the anticoagulation of choice because it prolonged filter time and decreased bleeding risk. And a recent meta-analysis confirmed that. And so I think that KDIGO, the new guidelines, will probably make a comment on that. The issue with citrate is that there are like 10 different protocols out there with 2 different types of citrates, ACDA citrate and trisodium citrate. So unless you've been trained on citrate and you know a lot about it, or you devote yourself to learning about it and starting a program, doing all the protocols, it's not easy to implement. And so you really have to have a unit that is committed to trying to save costs by prolonging filter life and decreasing, hemorrhagic complications. And so it's clear there's a clinical benefit, but it's still split up: 30% citrate in terms of utilization, 30% regional heparin, and then 30% nothing. There are programs that just do CPVH, for example, and do everything pre-filter. They don't need, they say, they don't need regional anticoagulation. However, when you compare citrate versus every other technique, to include thrombin inhibitors, citrate comes out on top every time. And so there is a movement to try to have citrate be more widely adopted across the country. Here's the other problem: citrate is not FDA approved specifically for regional anticoagulation on a renal replacement therapy platform. And so trying to make that argument is despite the KDIGO guidelines is a problem. And so heparin is. And so those are some barriers. Obviously, for citrate, you got to check ionized calcium. Sometimes some centers don't do that for the sake of efficiency. They just know that the ratio of citrate to blood flow is specific and sufficient enough. It needs to be 2-to-1 to maintain an ionized calcium goal of less than 0.4, which is when you get the anticoagulation effect, inhibition of coagulation factors. And so they won't check it. They'll just spot check it. But there are some strict protocols that check it every 6 hours. Again, a lot of variability in practice. You could say the same thing about heparin. There are some that use regional heparin, some that use, at low dose, and then the body metabolizes it, and you just check, PTTs every so often to make sure the patient's not like sitting with a PTT at 240, that kind of thing. Or they reverse it, post filter or right before the blood gets returned back to the patient, or they do low dose Lovenox or something like that. I've seen heparin versus and plus a prostaglandin, mixed in, which seems to be pretty good, but very small study. But regardless, there's a wide variety of techniques, and it really depends on where you trained and what you're willing to implement in your practice. And everybody has to be on board. In my unit in the burn center, we started out with citrate because I was afraid of the bleeding complication of heparin. And then we had a national shortage of calcium. And so if you're doing citrate, you got to be able to replace calcium. And so that was a problem. And so we went with heparin. I did notice filters clotted a lot more, but we dealt with it. And then I think now they've used a combination, one or the other, depending on dealer's choice, whoever's prescribing. But again, data suggests citrate is superior.
Awesome.
I think, I am a big believer in CRRT, but I know that many people have gotten pushback when they try to implement CRRT programs that it's, quote, too expensive. That the bags, costs X many hundreds of dollars, and there's often pushback at institutions that like, can we really afford to do CRRT as opposed to intermittent hemodialysis? What are your thoughts on that?
Yeah, I think it depends on the business case analysis at the hospital and who's doing the business case and how they're doing it. There are clearly disposable costs involved with a CRT program that you need to consider. However, it's offset by the fact that you're able to utilize the ICU nurses as your experts who manage the CRT circuit and everything else, and so you don't have to pay the cost of around the clock dialysis techs. And so depending on how much you're paying dialysis techs for delivery of intermittent dialysis or SLED, it really depends on the numbers that you plug in. And so and also if you have a program that's relatively mature, you'll have one nurse, ICU nurse, skilled ICU nurse, delivering care and managing the CRT machine. If you're a new site and new to CRT, you may have one nurse doing CRT while the second nurse, so it's 2-to-1 or sometimes, right? Or they'll be managing, you have a CRT nurse managing two machines. So it really depends on the model of care that you have at your institution. And you will get the argument that hey, we don't think it's cost effective. My counter argument would be, well, at least establish a SLED program, because if you're able to do SLED, you're at least able to do intermittently, continuous therapy, right? So for the sickest patients, you're able to do the Fresenius and eat the cost of having them, having dialysis techs come overnight and running the machine and doing it 24/7 as long as the patient needs it. And so if that's infrequent, I think that's okay. If you have a ton of hemodynamically unstable patients who would potentially benefit from CRT, you really have to lean towards CRT. It depends on disease severity, acuity of the ICU, and the types of nurses you have, and how many dialysis techs you have on board in your hospital.
Right. I think, I think in my center, we're really fortunate to have really great nurses who, have all of the skills basically, who can run, devices like Impellas or balloon
Yeah,
pumps, can run
exactly.
ECMO, can run CRRT. And
Wow.
so, it makes it easier to sort of arrange the pieces and staff for
Right.
these really sick patients, as
Right.
opposed to try to get external people to come in and do something. And I always wonder, like, what is the opportunity cost of that? Is there somebody who's not getting their Monday, Wednesday, Friday dialysis because the tech has to be in the ICU? So, like,
Yeah.
I agree with you. It's interesting. I think that it kind of depends on which budget you're looking at. Like, it looks
Right.
more expensive to the ICU budget line, but
Right.
if you think about the system as a whole, there's
Yeah.
probably, significant economies where it's equivalent or maybe even cheaper in some cases.
Agreed. Agreed.
Awesome. I think great discussion in regards to sort of the financial element of that and how you can sort of parse that. Kevin, we've been talking for a good while about CRRT, and I think there's a ton of great content here that I hope our listeners will appreciate. One thing we've yet to talk about, we talked about when to start CRRT and kind of timing that, but what about timing as it relates to ending CRRT? How do you approach a patient in regards to when you're either going to transition them to IHD or when you actually think that they are ready to come off of any sort of renal replacement therapy?
Right. Thanks for that question. I think there's some practice variation there. There are some units that won't have patients come off CRT until they are ready to leave the ICU. Okay, so they need to meet criteria for being able to be downgraded. However, in general, um, in terms of transitioning from CRT to intermittent, in general, once you have relative metabolic control, you don't need to wait necessarily for renal recovery to transition to intermittent hemodialysis. And many ICUs have this practice model where you do CRT for a time period, get them metabolically controlled, during the phase of acute illness where they're hemodynamically unstable. Once they achieve hemodynamic stability and a fluid balance that they're comfortable with little wiggle room, then at that point, hemodynamic stability is defined by they're off of pressors and they're not getting boluses to maintain soft maps, then they're eligible for transitioning to intermittent. Sometimes it doesn't work. They got to go back on CRT, but that's an acceptable model. The other model is the other scenario is they're on CRT and then they start making urine. And urine output towards, like, in terms of renal recovery, is the best predictor of renal recovery. And so you can at that time either come down on your dose, the effluent dose, and see if there's a bump in your BUN and creatinine the next day, or just stop it altogether and see if there's renal recovery. And that could be a technique as well. So, I hope that answers the question.
Yeah.
It's all about physiology and individualizing timing of coming off, transitioning to intermittent, or coming off entirely based on what the patient is giving you.
Absolutely, yeah. So it sounds to me like, once the kind of initial big insult has been mitigated, that might be a signal to you to look for some urine output, and then perhaps if the filter's down or if they're going for a procedure for a while, they're not getting CRT, and all of a sudden they come back and go, oh, the Foley bag's got some urine in it. That might
Yeah,
be an opportunity to, I don't know, hit them with that Lasix challenge again in the not too
yeah,
distant future. See if you can sort of quote unquote get some awakening of the nephrons, and then perhaps that's a way to move forward.
yeah. And I always look at rate of rise of creatinine, and so if it's like not one per day of creatinine going up, and it's like a fraction of that, then you know that there's some intrinsic renal function at least coming back.
Thank you. Great.
Mhm.
So I think, we've covered a lot today, and I think we would be remiss though if we didn't ask you, to talk about one more kind of area, which is that, we think about CRRT and HD as removing things like potassium and urea, but they can also remove lots of other stuff. They can
Right.
remove cytokines. They can remove specific cells. So,
Mhm.
and this is of course an area that you are an expert in. What can you tell us about other types of filters, other types of blood purification technology?
Yeah, thanks, Nick. I think one of the things that got me into this, this field and this interest in blood purification in general is because I was desperate. We would have patients on regular doses of CRRT, and they were, metabolically deranged on three pressors, and they just wouldn't do well, and they would be dying. And so it was clear to me that standard of care was not enough. And so because I didn't know any better. Remember, I'm not classically trained, so I could do whatever I want. And so
Not
You could feign,
constrained
you
by
could feign
not
ignorance.
constrained by the orthodoxy.
Yeah.
exactly. So I dug into the literature. Ran into this guy Patrick Honore who wrote a paper on high volume hemofiltration and cytokine removal, and I was like, okay, I'm going to try that. So I did CVVH at 70 to 100 cc's per kg per hour. So that's like 6 to 8 liters an hour. You need a blood flow of at least 400, 450. People thought I was crazy. Like the nephrologists were like, you're gonna make the patient's hemodynamic unstable. But I saw the complete opposite. We observed the complete opposite. Patients were coming off pressors,
Hmm.
and so we did a observational study compared to controls, historical controls. Of course, showing improved outcomes. Of course, it was they were like, oh, this is a randomized controlled trial. So we did a randomized controlled trial, but it was very hard to do, and we only got like 36 patients. But we did demonstrate a decrease in pressure requirement. The whole concept of blood purification. Centers around the fact that convective clearance, this is for high volume hemofiltration, is able to clear middle molecules. And so a lot of the mediators, IL-6, IL-8, all the inflammatory mediators, some anti-inflammatory actually, are removed. And it's concentration dependent how you remove it. And so I had this philosophy, along with others around the world, that maybe high volume hemofiltration could be a technique that could be employed, and it could be effective. It and bottom line is just the way I've evolved my thinking over time is like, if it's like, imagine trying to mop up a pool, or mop up, let's say, just your kitchen floor, and you have your sink faucet on, and it's overflowing onto the floor, and you're mopping up the pool or the floor, right? Yeah, you're gonna get some water into the buckets, but you're still gonna be flooded. And so that's the analogy I use a lot of times when you're trying to do cytokine removal. You got to figure out how to get source control, shut off the faucet, or do it in combination. You can't just mop up the floor, right? You got to shut off the faucet. And so we've so, by the way, there's high volume hemofiltration as a technique. Regular dose hemofiltration does not work, by the way. It's not enough at all. There's also adsorptive technologies. There's Cytosorb, you may have heard about. It's a Chinese company, but lots of use in Europe. Jaffron is a very similar bead-based hemoadsorptive column where it basically binds mediators, inflammatory mediators, and maybe some other things. But it's not available. It's not approved for use. It had an EUA for a period of time for COVID, but there was a study in ECMO patients that showed an increased mortality, which was curious. But there is a lot of enthusiasm with Cytosorb, and I've personally had a lot of interest over the last 2 decades. So that's an absorptive column. Oxiris is manufactured by Baxter and is available, that can adsorb with an AN69 filter. So it sticks, attracts, inflammatory mediators, and has the ability to remove endotoxin. So it has the capacity to both. However, some would argue it's not enough endotoxin removal. It's not enough, adsorption of mediators. There's a polymyxin B, or toromyxin. The Tigris trial is a follow-on to the Euphrates trial. John Kellum is the CMO of the company Spectral Medical, and they just enrolled 90 subjects. So they're halfway. That's it. They're at the point of interim analysis. I'm really excited about seeing the results of that study, because it's a follow-on of the Euphrates study that didn't show any benefit overall, but there was a subgroup of patients where they had an endotoxin activity of 0.5 to 9. So just right, not too low, who didn't benefit, not too high, all those patients died, just right in between. That's the Tiger study, and so we should be looking forward to that, because that could change, our practice, polymyxin V, if it comes to the market. And then the selective cytophoretic device, this whole concept of mopping up the floor, shutting off the faucet. Where are the cytokines coming from? They're being generated by activated neutrophils and monocytes, and we're addressing that with our device. And we're currently conducting the Neutralize AKI study, a pivotal trial that will hopefully bring it to market. We had exciting news today. The humanitarian device exemption in pediatrics. Stu Goldstein led that effort from University of Cincinnati. He's a big AKI guy, and he helped us tremendously bring this technology to the market for the pediatric population. Since when have you ever heard of a technology being available for children before adults? This is a technology that was invented by Dr. David Humes from University of Michigan. The reason I joined the company, actually.
I guess ECMO, in a sense, was initially used in pediatric populations, but
yeah, that's
yeah,
right. You're right. But in terms of FDA approval,
yeah, absolutely.
Yeah.
Yeah.
So that's very exciting, and can't wait for all these. I think all these blood purification techniques are complementary in nature, and a win for one is a win for all of them. To be honest with you, and I can't wait for the day that we are able to, as intensivists, pick and choose the modality of blood purification based on the patient that is in front of us. Oh, I forgot to mention Seraph, which is again, a adsorptive column that is able to remove pathogens from the blood. And so that was a derivative of dialysis-like therapeutics program, a big DARPA program that was in existence that was a part of years ago.
I don't know, Nick, if you've used these devices. I've used the last one you mentioned. I think that's from Xthera Pharmaceuticals, if I recall. And it was in a patient in the burn ICU that was on like 3 or 4 pressors, had horrible gram-negative sepsis. And we really were out of options. And this obviously it's an N of 1, so I will say that. But in this particular case, within like 6 or 8 hours, the guy's pressure burden dropped dramatically, and it was pretty impressive. So I'm also very excited to see what the research shows going forward, and hopefully it's another tool in our toolbox to take care of the sickest of the sick.
Yeah, I think I got to admit, full disclosure, that I was initially pretty skeptical of these technologies, and I'm sort of coming around to it. I think, seeing how many different products there are out there, and seeing how they're targeting different aspects of the immune response is very interesting. I think COVID was very illuminating in the sense that, like, we for the first time really saw success of therapies like JAK inhibitors, IL-6 inhibitors, use of steroids, like, that really turning off the faucet, to use your analogy, was proven to be life-saving in this disease. And I think, thinking about that in the future beyond just COVID, I think is a really important place for critical care to go.
Yeah. My final comment on that blood purification thing, there's this concept called SETS, sequential extracorporeal therapy, where you're able to combine 2 blood purification techniques, and we've been able to deliver that. Jeff Della and team at Methodist in San Antonio had a patient very sick, after C-section, group A strep toxic shock, same thing, multiple pressors, started on ECMO, VA ECMO, then subsequently placed on Seraph for about 24 hours, and then 7 days of SCD, the selective cytophoretic device. There's going to be Critical Care Explorations just picked up that paper that they wrote, and it should be available soon.
And I think that's a really key point too, which is that, if somebody is on ECMO or CRRT, right, their blood is already going through a circuit. The added risks of doing one of these technologies is very, very low, right? That most of the risk is baseline risk from the device they're already on.
Agreed. And the FDA agrees too.
All right, so guys, we discussed a ton of awesome CRRT kind of pitfalls, pearls, just a ton of great content. Just to sort of summarize from soup to nuts, we started by introducing Dr. Chung, his interests in extracorporeal therapies. He is, a wizard in that regard, and perhaps I'm biased. He's a friend and mentor to me personally, but has really, he talks the talk and he walks the walk. So I think we're very happy to have him here with us today. After we sort of introduced the concept, we talked a little about AKI. how we approach that as intensivists, options before you initiate renal therapy or renal replacement therapy, excuse me. And then we rolled into, I think, a nice discussion of renal replacement therapy to include the physiology, the modes, some of the actual indications. Nick, I think, brought up that idea of the economy of CRRT and how that can kind of be viewed in different ways. And then, we talked about anticoagulation. We talked about how one can come off of CRRT. And then finally, we spent some time talking about blood purification technologies and how those could usher in a new mechanism through which we could care for our patients in the future. So very excited about that and everything we discussed. Certainly, if you want to learn more about these topics that we discussed, other topics from previous episodes, please check out our show notes, infographics, and all the other content we've got on our website, which is www.criticalcaretime.com. And while you're there, you can subscribe to our mailing list and leave us a comment. The mailing list, we're hoping to launch that in the next few months, so stay tuned.
And with that, we come to the part of our show where we'd like to say thanks. First off, thanks to Dr. Kevin Chung for being our guest. We learned a lot today. It's great to have you. Thanks so much. We'd also like to thank all of our listeners. You guys really give us great feedback and keep us going. Several of the questions that we asked today were suggested by you, so thank you for that. We do listen to your feedback. If you like our show, please leave us a 5-star rating. It helps other people find us. You can subscribe to us on your favorite podcast app. This helps us, grow the show. And then keep giving us feedback. So tweet or X at us at Crit Care Time or individually, Nick M. Mark or at Askins Razor. Follow us on Instagram, Threads, YouTube, you name it, we're there. Kevin, do you want to share your handles?
At Chung K 1031 is my Twitter or X handle. That's probably good enough. And I just want to, say thanks, guys, for this invitation. I had a blast, and congrats on all your success on your podcast.
Thank you.
Thanks for helping us.
We appreciate it. And that's a great way to dovetail into our big thanks to C-Star Medical, our sponsor for season 1. We're fortunate and very grateful that this episode and all the episodes for season 1 of Critical Care Time have been sponsored and will continue to be sponsored through the duration of this season by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Please check out their website. It's cstarmedical.com or SEASTARMEDICAL.com to learn more.
And then before we go, we'd like to thank the members of our team who help us put this together, helping us with research, writing, etc. Our producers over at Podpaste who make us sound good and edit out all the stupid sounds we make on the microphones. And then finally, the music you hear right now, composed by Kurt Belknap. Thank you very much for the theme music. Disclaimer time. So this podcast and all that related media, the website, the infographics, etc., please share them near and far, but just acknowledge where you got them from.
And finally, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. Thank you so much for listening. Thanks again to Dr. Kevin Chung. I am, as per usual, Dr. Cyrus Askin.
And I'm Dr. Nick Mark. Thank you all. See you soon.